So let's talk a little bit about angina. We guys obviously know how it feels like, what the symptoms are. But I'm not sure that all of you guys realize the scope of the problem. I certainly didn't before putting these slides together. It turns out that more than 100 million people worldwide are affected by this problem. It obviously causes significant disability with disabling symptoms. Patients are on multiple medications, including obviously a lot of side effects from those. And then the hospital care for these patients is enormous, with them having numerous admissions for this problem. And so it turns out that what we do with these patients when they come to the hospital is to do an angiogram. So we do over 2 million angiograms, both in the US and in Europe. And about 1.2 million of those patients end up having either PCI or a CABG. But about 500,000, which is a quarter, I mean really a huge number, is estimated to have ANOCA or angina with non-obstructive coronary disease. So that's also a whole field of patients where I think we don't have great therapies to offer at this point. And of course, this is a recurrent issue, even when those patients that have some form of treatment have frequent recurrences. Now, the good news is that the outcomes in terms of the hard, quote-unquote, hard clinical endpoints of these patients is not so bad. The long-term mortality of patients with refractory angina, which obviously is the worst of this patient population, is relatively low, around 4% or less per year, and very comparable to those with patients having chronic ischemic heart disease. The major risk factors are advanced age, advanced angina class 3 or 4, or LV dysfunction. So those are the patients you might have to kind of tailor therapy more aggressively towards. But for the rest, really the goal of therapy is symptom relief, because you can't really improve much on their prognosis, which, as mentioned, isn't so bad. And so before we talk about what we can do for these people, we have to kind of understand the different buckets, right? Who are these patients that we're talking about, and what is causing the problem? And so this is kind of a large overview of what we're dealing with. Probably the most common are diffuse CAD or obstructive CAD that is not amenable to interventional therapy, and microvascular disease. Those are, I think, the bigger buckets, if you will. But there's, of course, anomalous coronary origin. There is, LVH, a mismatch between supply and demand. So there's obviously also a bunch of other reasons. But I want to focus on the three most common ones, which are obstructive CAD with no good interventional options. The large patient population actually has intervention and still has remaining chest pain, and then the ANOCA population. So this is one case in our group, that a patient we have been following for a long, long time with recurrent in-stent restenosis of the LAD. So this is 2010 already. He had restenosis, at which time he had rotational atherectomy of the entire stented segment, with actually a reasonably good result. I'm not sure today this would be, the first therapy we're using, but actually it looks okay in this case. But of course the problem is he comes back a few years later with the same issue, and at that point a second layer of stent is placed. Again, every time we do something it looks okay, but then he comes back. So this is now 4 years later. Now he has recurrent in-stent restenosis. At that point laser atherectomy is used, again with a reasonably good result. And then he comes back a few years later after that and now has a CTO. And the CTO is recanalized, but of course it came back with another occlusion. So this is just one example of a patient over a long time, almost 15 years, that has the same issue in a recurrent fashion. And again, we don't have great therapies for these patients. And this is not an exemption. As you see, when you're looking at basically all the major interventional trials, it turns out that the recurrent angina rate is about between 20 and 30% in the PCI group. This is not the patients that are assigned to medical therapy. These are PCI trials. So even with PCI, the recurrent angina rate is high. And I want to highlight the ABSORB trial. I think this is kind of an interesting trial because I guess of the premise that the scaffold, the ABSORB stent, would improve vasomotion and potentially lead to better angina outcomes. And so it was very, very closely monitored. I mean, Greg obviously was the PI of the trial. He knows how this was done, but it was a very, very meticulous regimen. And so we have very good data on quality of life and recurrent angina. And as you see here, I don't want to look at the difference necessarily between Xience and Absorb because there was none, but the bottom line is that in 40% of cases at 2 years, angina recurred, again, despite a successful intervention. And this is not just limited to PCI. We have the same data for CABG. In the major CABG trials, the rate is about 25%, very, very similar. And the problem with that, despite the problem that we have in this patient population is that these patients are very, very symptomatic. They come frequently to the hospital. They consume a lot of healthcare resources. And as you see here, when you're looking at this patient population, you know, the more advanced CAD we're dealing with, including microvascular disease, the more healthcare cost we have in this population. So this is where we stand. We know chronic stable angina is a very, very common medical condition. We know that the prognosis overall is good, except for a few patients who have high risk factors, but the quality of life is significantly impaired in this patient's population. The etiology is dependent, is different, although the major buckets, as mentioned, are patients that have quote-unquote successful PCI and still have chest pain after that, patients who don't have really good treatment options, and patients with microvascular disease. And there's no question that we need new treatment modalities for this difficult patient population. Thank you.